slideshow. Can you see my slides?
Yeah.
Yes.
Cool. So this is like the highlight of my year work-wise. So there's it's called the British Thoracic Society. It's just a professional organisation for respiratory doctors all over the UK, and they do have some beyond as well. So we did this last year for the first time. So this is the second time we've been. And in the big exhibition hall where everyone goes in the breaks, we got them to give us a little table at the side, and we took in all different, like the leaflets and bits of information about NAC, and just talked to respiratory people all day for 2 days. So it's a really nice mix of clinicians as well. So it's not just like consultants and doctors, it's the full team. So there's physiotherapists, pharmacists, nurses, people that are more some of the charities, like the idiopathic pulmonary fibrosis charities. Well, hang on. Graham, could you? Oh no, hang on, it's mine. Sorry. Once he starts, he doesn't stop for half an hour. Sorry, there's like a weird bin land train that goes under our window, and it's very noisy. Oh yeah, so we went to the British Thoracic Society meeting, and we talked to all different people who were interested in the service, and we got a lot of really useful information about what people want from the NAC service. And some of it was maybe a little, it's not always what we think. It's really useful to have just in-depth one-to-one conversations with people. So a lot of people, most of them know who NAC are, and a lot of them have referred patients in, which is great. But a lot of them, they didn't know everything we do. They thought it was just referrals and that's it. But actually, once we got talking to them, they were really interested to hear about all the other stuff we offer. So like this group, quite a lot of the doctors took a flyer so that they can pass that on to their patients and see if they want to join. And things like, we have a thing, it's called a remote MDT. So if somebody has a patient and they're not sure if it quite warrants a referral, they just want a bit of advice and maybe just sort of check it out a bit, they can on Teams, they can basically come to our departmental meeting and tell us about their patient, and then get the whole team to weigh in and give them some advice about what to do, which is really good. And we're getting more and more people joining this. It's getting really popular. So a lot of them are really interested in that. And things like that, we've got the laboratory, and what does the laboratory do? What tests does ours offer that their centre doesn't? How do you how do you send the samples off? So in this photo, you can see there's Aminda Babra, who's one of our nurses at the moment, and she very kindly came along and helped run the stall with me, and that was really useful because she could give a lot more detail about the nursing side of things, which I don't know as much of the detail on. And she brought some samples of the postal packs that we send out to you guys, and people were very interested in those, and how we use them, like what do we test the sputum for, and just all the real nitty-gritty of who is it useful for, how do I get one, where do they get sent. People really appreciated being able to just pick up the materials and just properly look at them and just ask the nurse directly. So that was very handy. And also it gave us a chance to find out what they need from us. So one of the things that was really I think people are crying out for is leaflets and advice about managing side effects of all the azoles. Quite a few people said we're desperate to know how better to do this, especially for long-term treatments, because they put people on the antifungals, but then the side effects are so bad that people can't tolerate them, and then they come off them again. There's a big need in the UK, just really practical advice on how to manage the side effects. So we're putting something together at the moment to send out to them to try and help people not get so gross and sick from the medication that they desperately need. Oh, ignore the thing about the costs. That was for somebody else to look at. Excuse me. We had a big banner that was a new thing I made this year, and quite a few of the doctors, they wanted copies of the patient booklets that we give out. So I think, like, we weren't sure whether printed items were really what people want anymore in this day and age, but I think people do like having something colourful to hold in their hands sometimes. The other thing that I made new this year was we've got a new leaflet now, and it's "Why does NAC have specialist nurses?" And it's got the photos of our nurses on the front, and it just describes in a bit more detail about how aspergillosis patients might be different from like a ward nurse or general respiratory nursing. Just the things that you have to think about. Um, and it's got a little they did a little audit of the phone number that you phone the nurses when you've got a question. They collected some data about how many people phone and what all the different questions are about, which is that's quite interesting as well. And it's given us some ideas about what we can change in the service. So we're going to me and Aminda are going to hopefully be working on a couple of videos, just quite basic things like how to use the postal packs, like literally just like they come with a leaflet, but sometimes it's a bit difficult to quite picture what you're supposed to do from a written leaflet. So we're gonna make a video of just watching us do it. Um, and yeah, just a little bit on the back page about the side effects. And a few people took that, which was nice. We this isn't very interesting actually. This is just how we promoted it and tried to encourage all the people at the meeting to come to it. This weird zebra lungs thing, there was actually there was only one talk about aspergillosis in the whole thing, but it was really, really good. Um, Hopefully we might be able to get a copy of it somehow, or maybe ask him to repeat the talk for us at some point. But it was to tell all like huge big audience, like several hundred doctors at once, all the different subtypes of CPA, of aspergillosis, sorry, and why the different features of the different kinds, how that correlates with what you see in the test results, and how that relates to what's gone wrong with a person's immune system. So that's very, very important, because if a respiratory doctor doesn't have a good grasp of all the specific different types of aspergillosis, there's there's a risk that they could misinterpret a test result, or miss something. So that was really, really, I thought it was a very, very good talk, very, very clear, but really, really useful. So it's a good educational outlet. And we sent a newsletter out to all of them. And I'll be writing a blog post about this on aspergillosis.org if anybody wants any more details about this. Um, cool. So, alcohol, aeroplanes, and oxygen saturation. I think these people are in first class, which I never have, but that's okay. So there is actually a clinical statement written by BTS, whose meeting we were at, about air travel for passengers with respiratory diseases. That's not just for alcohol. That's loads of different tips. I'll put this link in the Facebook group as well later. It's a bit of a big document, but if you struggle with flying, it's quite a good thing to just have a skim read, see if they've got any tips that you might not have heard before. It's got quite a lot of different things in, because like air travel it's not just the sort of the physical, that the air is very dry and recirculated, isn't. There's a lot of things, like taking medications through security, uh, managing heavy bags up and down stairs and things. Um, and what you're allowed to take in your hand luggage and things that you need to keep well, and who to contact in advance to just check, is it okay if I bring this? It can get very complicated. And don't even get me started on travel insurance when you've got health conditions, because yeah, my poor parents, they're them trying to get insurance. They're healthy, but dad had a heart attack a couple of years ago, and it was very, very, very difficult to find a mainstream company that handles the travel insurance properly. So yeah, if somebody uses oxygen or something, it can get very, very complicated. So I'm not going to attempt to tackle the whole subject right now. We're just going to pick off this little bit, which is, why is aeroplane drinking even worse for respiratory patients? So one of the big things about aeroplane air, it is horribly, horribly, horribly dry. And if all the mucous membranes inside your sinuses and your inside your lungs, they can get quite dry. And alcohol just doubles down on that, because it's dehydrating. It makes you pee more. And if you've already got quite a lot of inflammation, it can get more sore. And if you've got like a lot of mucus in there, like especially if you're ABPA, if you've got a lot of mucus going on, it can dry out more and get harder to cough up, which obviously is not ideal. When you're obviously, everyone knows, the air pressure's different as you go up. It ends up, you get just from that, you will get a lower oxygen saturation than you would at full air pressure. So even just going on the plane itself, your oxygen saturation will dip a little bit. That's for everyone. Um, it will tend so for your circulation, it's dreadful for circulation. So if obviously alcohol dehydrates you, unless you're drinking a load of water as well. And sitting still is, especially if like a transatlantic flight, if you're sitting still, very, very, very constrained, because I swear they make the seats smaller every year, or I'm getting bigger, I don't know. It could be that. When you're not moving around, your blood circulation, it's not moving. And that's bad for so very many things. Um, Another thing is, sort of when you travel, you tend to not be eating the foods that you normally would, like maybe have some chips at the airport, or you have one of these weird, um, strange aeroplane meals. Um, is that really why? Ugh.
Really, aren't they?
So sometimes some of them are good, I guess. Yeah. But basically, you're changing your food routine. You might be eating at really strange times of day, and if it's late, you might end up eating something kind of heavier and greasier. If you end up getting a load of indigestion from that food, and then on top of that have alcohol as well, which can also give you indigestion, you have to bear in mind that if you're on antifungals that are affected by stomach acid, you might need to bear that in mind. And also, just so just before you go, depending on which tablets you're on, just be aware of the absorption, and if you need to take them with food, without, or after food, and if it's one that needs to be acidic to be absorbed, just remember that if you have an antacid, that will change your stomach acidity. So it's just remembering all these little details can be a bit of a hassle, um, and it's easy to forget in the moment. Uh, Inflammation from alcohol. So the reason I've put a glass of red wine is because, like we'll see in the newspaper all the time, is red wine good for me? It has resveratrol. That's healthy for the heart. In small amounts, it can be, but it depends. I think there's a temptation on holiday to overdo it a little bit. So if you drink enough that you feel a bit crummy the next day, then you will be causing extra inflammation and oxidative stress on your whole body. And if you've got a lot of it, if you've got sort of lung inflammation problems, you probably will feel it. So um, if you're going to indulge, maybe just not too much, not too much. And the other thing is CPA. It there's not so many people that have just CPA. They tend to have people tend to have other respiratory things on top of that. So COPD, also things like diabetes. So alcohol will do things to your blood sugar. Cardiovascular problems, alcohol will affect that as well. And sleep apnea as well is if you have a couple of glasses of wine before bed on holiday, the chance, especially like if it's sort of quite hot and humid outside, even if you're not normally that prone to sleep apnea, it can make a difference. It can sort of relax all the muscles around your throat, and so you might not sleep so well, and then you wake up feeling worse. So all of it's one little glass of red wine in itself is sort of innocent, but when you add in all of these things on top of each other, um, there is a risk of kind of getting away from a good like a good routine for yourself. So how much difference does it actually make? So I found an article in the Limbic, so there's just a link there, and got a quote from that. So it said, a German study that they looked at involving healthy young people found that moderate drinking, which I think was like a glass of wine or two, worsens the drop in the oxygen saturation and the faster heart rate that you get during sleep in mildly hypoxic conditions, such as those aboard a commercial flight. So basically they were trying to mimic. They were getting just sort of normal young healthy people without health conditions, and trying to mimic what happens if they fell asleep on the aeroplane. So the way that's measured is they have the SpO2 monitor, the clippy that goes on your finger, and it's a little bit arbitrary because people are different, obviously, but a cutoff that a lot of them use is if it's less than 90%, they call that clinical hypoxia. So something that's really really relevant to your health at that level. So what they used for this experiment was they had 2 glasses of wine before they went to sleep. So at normal pressure, when they just went to sleep, their oxygen was at 91%, and when they had the wine, it didn't fall that much. It was only to 90. That's not too bad. But when you factor in the pressure, the low pressure in the aeroplane, just falling asleep on the aeroplane alone, their oxygen was already 88. It was already a little bit under what it should have been. And with the wine as well, it fell at a few percent again to 85%. I find those numbers, that was a lot more than I was expecting. And also, they measured people's heart rate, because the heart rate, it's a bit of a rough and ready measure, but it gives a bit of an indication about how much stress the body is under. So when they did this with the aeroplane and the wine, people's heart rate went up from 73 to 88 beats per minute. That is quite, I think that is quite a jump for somebody who's just sitting quietly, for their heart rate to go up by like 15 beats per minute just because of this. That's quite a jump, I think. So 2 glasses of wine, it will make a difference. And if you fall asleep straight after, which, let's be real, if you had 2 glasses of wine and you're sitting in a comfortable chair, I think most of us would. If you just, if so, like, obviously, like, we're not telling you what to do. Like, you've got your own decisions to make. If you decide you would like a glass of wine on holiday or even on the aeroplane, there are some ways to sort of mitigate it a bit. So it sounds obvious, but all these things can go out the window a bit when you're in the holiday spirit, drink plenty of water. Like if you have a glass of wine, have a glass of water afterwards, and make sure you drink plenty of water before you go to bed as well. And especially if it's hot out. And if you have wine in a restaurant, just get some water for the table as well. Just keep on topping it up. It really is best if you have a glass of wine, just make it one, or you can even like share one with your partner or something if you just want just a little taste. On the aeroplane, it's really, really, really good to stand up and stretch or do some kind of in-seat exercise, just like heel lift or stretching your legs straight out, something like that, at least every hour. You can also for circulation, you can also wear compression socks. So ever since my dad had his heart attack, his surgeon told him that everyone should wear compression socks on the aeroplane. So on family holidays, he makes us all wear them now. So I'm always sat there in my seat with these horrible nylon elastic things up to my knees, and I get some weird looks, but okay, it's better than getting a blood clot, I guess. They look weird, but they're not that bad actually. So it's something to consider. And also remember to look after yourself extra well before and after. Like eat plenty of veggies and make sure you've been sort of doing the right amount of exercise for you. Obviously, if it varies between people. And this is this last bit. This is absolutely not official NHS recommends. This is something that I found on an airline website. So there's no data to back this up, but they reckon that if you are going to drink wine on an aeroplane, it doesn't actually taste right anyway. So with the low pressure and the very, very dry air, your sense of taste is reduced by about a third straight off. Everything will taste 30% less of anything. But it doesn't affect the different parts of your sense equally. So all the subtle flavors will be pretty much lost, and sweetness is lost as well. The main stuff that you'll be able to taste is acidity and tannins. So tannins are, with red wine or tea without milk, it makes your mouth kind of pucker a bit. That's the tannins. So, and that it just becomes a bit acrid and unbalanced. And if it's something with bubbles in, because of the air pressure, the bubbles aren't right either. So you don't get like the fine champagne bubbles. They're much bigger and they just stick to the edge of the glass. So the texture's all wrong as well. So if you absolutely are going to, don't order champagne on the aeroplane. It's not worth it and it will taste crummy. If you absolutely have to, they recommend Chardonnay, Shiraz, or Merlot. But
I also recommend those three.
I always order Malbec because my friend that liked wine, that's what she orders. I have no idea about wine. And if you want some little exercises, there's absolutely tons on YouTube, all different options. It sounds a bit silly, but one thing that I do is I take one of these elastic exercise bands, and you can actually do quite a lot in your seat without hitting anyone because it stops you from stretching too far. And that bottom left picture, that's my mum and dad on our holiday. I made them wear the masks. This was a couple of years ago. I made them wear the masks and they made me wear the socks. So we all look like weirdos together. Okay. Has anybody got any questions, or is anyone going on a holiday that they'd like to tell us about?
I've got a question.
Okay.
So, as with the last few months, I have opted to take questions from patients from our several groups that we run across the month, and probably mostly over the last week or two. There's been a series of questions asked, which I think make good questions for me to answer in an elongated way like this. I'm getting a lot of feedback. Why am I getting feedback? Yes, it is. Over you. So, a quick, as it's become customary for the last 5 years, who'd have thought 5 years? A quick look around the respiratory viruses that are in our air at the moment is the usual graph. Different coloured lines for different viruses, and this covers the entire previous year, 12 months of a year. And we have the one we're used to looking at, SARS-CoV-2, which is COVID, had declined at the end of last year and has pretty much stayed down there. And though you might say in the last month or two, there's been a little climb up, and we know there's been a few new variants around, but these things are just spreading. They're not really causing much illness. This data is taken from people who've gone to the doctor, gone to the hospital with flu-like symptoms, and they routinely do swabs of set numbers of those people as a surveillance for these viruses. And of those swabs, in the last week, because this is current up to I think the end of June, we've got about 5% of them were positive for COVID. More like 12, 13, 14, 15% are the common cold, or one of the common cold viruses, rhinovirus, and you can see that that's pretty much its level as it goes through the year. So there's nothing amazing about that. COVID might be gradually going up a little bit, but nothing too much to worry about. The flu had, as it nearly always does, has a huge peak around New Year. So more than 1 in 4, nearly 1 in 3 of these tests done had flu at the beginning of January, and that peak declines rapidly throughout the year, and we're now pretty much at a low. And no doubt when we get to sort of October time, certainly September, October, there'll be a big push for you to have your flu vaccines, because that will protect you against next year's peak. The only year we've had whether that peak hasn't been there was the year we were all staying indoors to prevent COVID in 2020 probably. And this RSV is the one that we're slightly more concerned about in the elderly population. This has generally been up to now been a childhood infection, but there's a rising number of over 70s who are getting this, and it's causing significant illness. So that group are now being offered the RSV vaccine earlier in the year to prevent exposure to that. So all pretty much calm on that front, and nothing too much to avoid. I think it's very difficult to avoid the common cold at the best of times. But we'll carry on keeping an eye on COVID and the other things. COVID, influenza, RSV are all things that we have vaccines for. Okay, so what questions were people asking in the groups this month? One that came up last week, or maybe recently, more recently than that, is biologics are obviously working well, and I'll talk about them a bit in more detail. But what's coming next? So I thought I would do a reasonable talk on that subject. So if I could just move that out of the way. So biologics? These are our brand new medications. Some of them are have been around for 10, 15 years, but most of them only around the last 5 years. They are only given by injection because they're monoclonal antibodies, a type of protein that our immune system uses to fight off disease. But these monoclonal antibodies have been designed to target specific parts of our immune system. This is unlike something like a steroid, a prednisone, which suppresses much more generally the whole of our immune system. These are much more specific. So the hope is that developing these to pick out particular targets in our immune system will be a lot less, have a lot less side effects than prednisone does. They are precise interventions aimed at key inflammatory pathways. And in our case, let's go on, next slide. These are the current biologics, and we are talking about them in the context of severe asthma, ABPA, and even SAFs, which are all allergic forms of asthma. And we currently have this list available for use. Up until about 5, 6, 7, 8 years ago, the only one around was omalizumab. That targets the allergy-causing immunoglobulin in our bodies, which is produced when we come up against something that we're allergic to, which is called IgE, and IgE triggers all sorts of other effects further down the line. So if you give someone an antibody to that target, it takes that target out of the sequence of events, and if you do that, you lower things like histamine release, and you lower the allergic response. So it's a fairly general, it's very specific, but it works in a kind of a general way because that will be useful against all different kinds of allergies, including ABPA and severe allergic asthma. Also things like, I think, eczema, it's used against in some cases. That's well known. It was originally marketed as Xolair, Xolair, but this is the name of the actual antibody that is used. Since then, there have been 1, 2, 3, 4, 5 more are available specifically around asthma and specifically around eosinophilic asthma, which is a particular type of allergic asthma. It does that by these different MABs for monoclonal antibody have different targets. Mepolizumab targets IL-5, benralizumab targets IL-5R alpha, dupilumab targets IL-4R alpha, and they are all very good. The first two are very effective against eosinophilic asthma, and most allergic asthma that we talk about is eosinophilic, so this is effective. We're increasingly find that these are effective against the types of severe allergic asthma that people with ABPA may have, but not all. Dupilumab, also asthma, but also eczema, and even effective against nasal polyps, which are a reaction to allergy, I guess. This one, the beauty of IL-4 R alpha is it blocks 2 for the price of 1. It blocks IL-4 and it also blocks IL-13. If you block 2, maybe you'll have more impact against what you're trying to treat, whereas these only block one thing. They're effective, but for some people maybe 2 could be more effective. Tezepelumab is different. It targets something called anilamine, which I'll talk about a little bit more in a minute. Whereas this blocks 2 things for the price of 2 parts of the immune system, 2 pathways, if you like, for the price of one, taking out one part of the pathway, because the pathway goes off in 2 directions at this point. This one actually probably takes out more than 2, occurs very early on in the triggering process of allergy. So because we're getting there earlier in the pathway, you might see it being useful for more different types of allergy, and you might see it being effective for more different types of patients. So increasingly, this is becoming the current treatment of choice for people with eosinophilic and allergic asthma, type 2 allergic asthma. And then restylizumab, I don't know an awful lot about, but it only targets IL-5, so it's very similar to mepolizumab, and it attacks the same target. But I presume these attack different receptors, so technically they're attacking the same thing, but in two slightly different ways. One way may be better than the other way, depending on the patient. It's all about refining the treatment to suit the individual patient that you're trying to help. The more options we've got, the better. What are these things I keep calling IL-4 and IL-5? IL stands for interleukin, which means between white cells. I presume that's Greek or Latin. I'm sure Beth knows her Greek and Latin quite well. No. They help immune cells talk to each other. And the whole point of having the immune system set up the way it is you have a trigger when an allergen comes in. You have part of the immune system recognizes it and triggers multiple other responses. So it's like a cascade. And these are the chemicals, if you like, that cause the cascade of immune response. That means we can react in a very major way to even at small stimulus. This is how our immune system works. You don't want an infection, our immune system to be slow to treat infections. You want our immune system to be quick and have a big response, and that's what this cascading does. Each IL discovered, and these ILs were being discovered since probably not long after the Second World War, so there's lots and lots of them. I think there's everything from 1 to 33 that we're interested in here, but there's a lot higher number than 33. I think there's well over 100 being discovered now, I think, and they trigger or regulate specific immune reactions. They are the guiding lights for how our immune system responds. And the particular ones we're interested in are the ones that are guiding immune responses that turn out to be involved in allergy, which is IL-4, IL-5, IL-33. In diseases like asthma and ABPA, other allergic or fungal conditions, ILs play a key role in driving symptoms. And they drive inflammation, and inflammation is, of course, our body's response to infection. It swells and becomes rich in blood because our immune systems are saying, come and look at this site where we've been infected, bring lots of killer cells, bring lots of white blood cells, bring lots of things to literally kill the invading bacteria. And to do that, you have to have a site of inflammation, which is great if it's an inflamed finger or you have an inflamed cut on your skin. But if the inflammation is happening somewhere like your lungs, then the inflammation can start causing trouble all on its own, because if you inflame your airways, obviously you can't get as much air in and out of your lungs. So inflammation or prolonged inflammation is not a good thing to have in your lungs in particular. Eosinophilia, this is the production of these cells that direct more and more other white blood cells into the area of inflammation. So if we can take those out, we would be able to cut down on inflammation. Mucus is something that we all know about. If you're having one of the first signs of you having an exacerbation is you start producing lots of mucus and coughing it up and plugs and all kinds of things, and the wheezing because your airways are starting to be obstructed by all this mucus and inflammation. So what's next? Have we reached the end of what we can discover? First of all, we have to look at what these different interleukins are doing. We know a lot about IL-4, IL-5. IL-4 interacts with B cells, which are part of how the cells that produce a lot of IgE, so that can drive allergy when they get out of control. In particular, the so-called type 2 immune cells, which are very much the sort of allergy pathway cells. IL-5 is similar, but it works in a different way. It stimulates the eosinophils to come to the site of interest and attract all kinds of other parts of the immune system, and you get a lot of inflammation. You see a lot of these cells in eosinophilic asthma, in ABPA, and in SAFs. IL-13 increases the culprit that is producing all the mucus and airway sensitivity, which is why it's co-targeted with IL-4 with dupilumab. They're going after inflammation, but they're also going after this trigger for mucus and airway sensitivity. If you can get both of those pathways blocked, then your medication will help your breathing a lot, which is why dupilumab is really successful for some people, but only if your inflammation is being caused by these IL-3 and IL-13 and IL-4 that's targeted by these drugs. We quite often don't know which one of these is most important in your situation, so doctors will try one, maybe dupilumab first. If that doesn't work, they'll go on and try others to see whether they're taking out the right target. As we get more and more of these, we'll be able to attack more and more targets and giving doctors more and more tools to tailor your treatment for your particular type of allergic response. IL-25 is another of these things called an alarmin, and really alarmins are the molecules that are sitting on the surface of the airways from damaged airway cells. And they're the very first bit, as you might imagine from their name. They are the molecules that sound the alarm. They are the interleukins that sound the alarm saying there's damage, there's something in the airways that we don't like. Let's get all the immune system cells in there to have a look and unfortunately then causing inflammation. Initiates the response. IL-33 similar, another alarmin, drives early asthma and fungal allergy. So I think what they mean by early asthma is asthma in childhood. And also this, which we came across earlier on, the TSLP, thymic stromal lymphopoietin, is the master trigger which is released from these epithelial cells and starts the whole inflammatory cascade. So if you can imagine, these are kind of at the bottom of the cascade. These are sort of in the middle, but the alarmin, and in particular this one, are right at the top of the inflammatory cascade, right at the top of what we want to get under control in your lungs in order to help your breathing. Okay, this is just an explanation of what I've been talking about, really. There's the trigger, which is the allergen, the fungus, the dust mite coming from the environment. The epithelial cells are the first thing to contact, get in touch with these allergens, because they are the things that are lining your airways. And these are the first thing the air touches, and the allergens in the air touch. These things release the alarmins, which are the early warning system, like a siren going off in wartime, triggering these different interleukins. These activate Th2 cells, and this leads to release of IL-4, promotes IgE antibody, in other words, allergy. And that's why you end up with 2,000, 3,000, 4,000 units of IgE in your blood when you've got ABPA, because this is being overstimulated. IL-5 recruits these inflammatory cells into the area that it wants to attract, wants to inflame in order to combat an incoming allergen. IL-13, as we've said, is in a separate pathway which increases mucus and airway reactivity. So these are all really important parts of triggering the response to you having an allergic response to an allergen. And what is type 2 inflammation important in? It's important in allergic asthma, ABPA, SAFs, which is a type of severe asthma with fungal sensitization, With the new definition of ABPA, SAFs is almost completely incorporated as into ABPA. So we might see SAFs as a definition, which is a definition we made about 20 years ago. I remember working on a paper involving SAFs. They will basically end up being called a type of ABPA, I think. Eosinophilic asthma, because the eosinophils are causing inflammation, which is causing the asthma. Nasal polyps and even dermatitis are all driven by this system I've been describing called type 2 inflammation. And the symptoms you will probably recognize: fatigue, wheeze, shortness of breath, a cough, either productive or non-productive, easy exhaustion on exertion, and these are the things that patients mention a lot: being exhausted, being fatigued, chest discomfort, pain and tightness are all parts of this type of lung inflammation. What does it cause? IgE causes the allergic reaction. The eosinophils cause tissue damage, inflammation, asthma flares. So when you have your exacerbation, it might be down to too many eosinophils being attracted into the site of attack. IL-13, mucus, cough, narrowed airways, long-term damage, airway remodeling. So if this carries on and is not treated with prednisone, which is the reason why we give you prednisone to damp down this immune response, you can end up with long-term damage and something called airway remodeling, and chronic symptoms occur, which is just your lungs adapting to this inflammation happening all the time, which is what we're trying to avoid. So I think we've already mentioned steroids and even antifungals now don't always target the root immune cause. This is where biologics come in. They can block specific type 2 pathways, not just everything all at once, but these specific type 2 pathways that we've just talked about. And we went through this a minute ago. So I now need to go through that again. This is a sort of a very simplified diagram of how omalizumab works. You've got your receptor, lots of free IgEs, which is caused by sensitization, IgEs, and allergens. So your IgE recognizes the allergen, the complex binds with these cells, mast cells. These mast cells then give out tons and tons of allergy-promoting chemicals, such as more IgE, and you start to feel very unwell. If instead we give an IgE which blocks a drug which blocks IgE, so IgG in this case is your omalizumab, which attaches to the IgE and becomes an IgE dimer, so-called, then it can no longer bind. The cells can no longer degranulate. You don't get any degranulation, you don't get any sensitization, and you should get a much reduced allergic response. That's really how most of them work. They are antibodies which attach to different parts of your immune system. It can be IgE molecule itself, or in most of the other cases, it will be receptors on the cell, the triggering receptors on cells that are blocked so that the trigger can't happen. This is just a simplified picture of all the different pathways that are involved in the immune system, and this is a small number of them. Needless to say, this sort of thing has taken decades and decades to work out, and until we'd worked out what triggered CD4 cells was IL-23, which comes from a dendritic cell, which also stimulates a Th17 cell, which stimulates neutrophils. It's incredibly complicated. And as I say, there's probably 70 years work in working all this stuff out. And many, many steps, important steps taken to get to this stage. We have got a few in here we would recognize. Tezepelumab attacks TSLP, the alarmin. The alarmin sat there right at the cell surface. Up here will be the airways. Here are the allergens coming in. TSLP wants to stimulate mast cells, wants to stimulate other types of cells, dendritic cells, and start this flow of allergic response. But you've blocked it using tezepelumab. None of that's going to happen. So the patient should feel a lot better. The asthma should be a lot better. Significantly, where there's omazilimab. Omazilimab works all right at the end of this long chain of events. So kind of more specific in a way, but if any one of these other things are part of the reason why you're having allergic responses with your asthma, then omazilimab is only going to have a relatively small impact. What you would need is something that works higher up. And mepolizumab, bemrozumab work higher up. Dupilumab works higher up. But right at the top, how do we say that? It's itepekimab, tezepelumab work right at the top. And these are the new biologics that are being developed right at the top. So here they are. Itepekimab targets IL-33, which sits right at the top, blocks airway inflammation from epithelial cells, blocks the alarmins. So there's a good chance that these things will have certainly have a different target, have a different impact, and people who are not responding to the other biologics may well respond to something like this. This is another one which is a similar type, attacking the same target, IL-33. This one is slightly different. If you can read all these, it's itepekimab, mab. This one ends in nib, which means inhibitor. And it's more of a, this is more of a traditional drug that you can take orally. And it is inhibiting a different pathway. But this may also be part of the new way to treat conditions. Getting trials in autoimmune conditions at the moment, but it may have some impact on asthma eventually. Amlitelimab has different targets again, modulates T cell activation in asthma trials ongoing, so this is also on the way. These focus on upstream alarmins, aiming to prevent inflammation before it starts, and that is the take-home message. The new generation of biologics aim to prevent inflammation before inflammation starts, instead of damping it down after it started. What most people, I would hope, would be aware that all of the biologics currently in use are designed for severe asthma and not ABPA, and are not really intended for aspergillosis specific use. We do use them, and they are effective against people who have asthma, but we know there are a few people who have ABPA who haven't got asthma, so we can't use these drugs for those people. There is work underway to test if ABPA will respond to some of these anti-alarmins, but they're not yet ready to test on people. And of course, nothing is licensed specifically for ABPA. That doesn't, not being licensed specifically doesn't prevent real-world use, but it means that the use has to be very careful and very and done by specialists essentially. But work is underway to work out whether one of them would be good for ABPA in particular. Emerging trends we just talked about: upstream targeting for the alarmins. Using them could prevent multiple types of inflammation, multiple different pathways of inflammation. It could take down the eosinophils, the allergic response. It can take down the response to fungus all in one treatment, which sounds really hopeful, But as we know, the more we broaden out the targets of a treatment such as this, like prednisone is very broad, you can increase the side effects. So that sort of thing remains to be seen, how good they'll be. New drugs aim to benefit patients with type 2. So not everybody is type 2 asthma. What have we got coming for those? And there are testing underway with these new drugs to see if they'll be effective in the people who have a different sort of asthma, if you like. And there is work underway to use biologics and antifungals together, particularly around where a biologic hasn't been particularly successful on its own. We're starting to see research on combining antifungals with biologics. And there's some indication that the biologics actually get more useful if combined with an antifungal already, along with antifungal vaccines. And as I think we talked about last month, there are antifungal vaccines in development, but they're nowhere near being used in people yet. But there's potential for them being used in combination with biologics, and they are currently in trial for this. And biologic de-escalation strategies. I don't know what that means at the moment. So what may we see in the next 5 years? The alarmin inhibitors, better control of hard-to-treat ABPA and SAFs. We're going to see more biologics approved for fungal asthma, so wider access through the NHS and international formularies for people with fungal asthma. Biomarker-targeted treatment, so a way of, instead of guessing what the right biologic is at the start and then running through, and maybe even running through 2 or 3 to find the right one, the aim is to be able to select the right one first or much earlier in that process. Trying to make biologics inhaled, as we mentioned, biologics are essentially proteins, they're antibodies. You can't take them as a tablet because the acid in your stomach would destroy them, but maybe you can inhale them because your lungs obviously aren't an acidic environment. So that would make it for easier delivery and fewer injections. You can imagine how that would make having biologics more palatable to some and probably cheaper because you don't have to have an infection, you just have to have a tablet or an inhaled nebulized form of treatment. And for a start, I know omalizumab has got a biosimilar, if not 2 or 3 biosimilars in development, and a biosimilar is the equivalent to if a company develops a drug like prednisone, they have exclusive rights to profit from that drug for a fixed number of years. Once those years are up, you have the generic forms of the drug developed in huge factories in India and South America. And those drugs then become massively cheaper. Well, we know biologics are very expensive and they're much more difficult to copy and to prove that they're the same thing. So we call them biosimilars. So omalizumab's got 2 or 3 biosimilar medications that are probably ready to test. I imagine they're at the testing stage because I've not seen them in use yet, but it's going to take a bit longer than normal to prove that a biosimilar is the same thing as omalizumab and works in the same way for the same patients. So that when they've got around all those technical issues, then we should see costs starting to drop for the use of biologics. Greater access because they're cheaper, especially in middle-income countries, like many of the African countries, I guess. Can biologics reduce dependence on steroids and antifungals long-term? Is a key uncertainty. We are having great results short-term and medium-term. What happens longer-term? They've not been in use long enough to know what's going to happen. Some people take these, get a month or 2 benefit, and then the symptoms start to return. Other people still going years later. So we don't know why that difference is, and we need to know a lot more about the longevity of these medications, because once we have confidence in the biologic acting for a longer period of time, then we can start getting patients off steroids and all the side effects, and off antifungals long term, reducing the dose of these and increasing the use of these would hopefully reduce side effects a lot. But at the moment, we're giving biologics based on criteria in specific patient groups, but we're constantly refining which patients get the best benefit and which patients don't get the best benefit for the different biologics. So rather similar to the point last time, when we know who responds best to a particular biologic, it means they get the right treatment earlier, which is always a benefit. And when, of course, will NICE, the UK NHS approval body, when what we don't know is when they're going to approve some of these newer biologics for ABPA or CPA-related asthma. They've approved the others for severe asthma. They'll probably approve the new ones for severe asthma. It's when they get around to actually approving them for ABPA and aspergillosis specifically will mean that more patients will get access more quickly. And at the moment, that's the key uncertainty for the use of these. But we're inevitably getting close to knowing when that's going to happen as time goes on. Okay, that's the end of that. Shall we? How do I do this? You see that? I think so. Some medication has to be kept at sort of 4 degrees, and that's easy. You put it in the fridge. Other medication has to be kept in the freezer, I imagine. That's easy. You put it in the freezer. But how do you keep medication below 25 degrees C when we're having heat waves and increasingly having hot spells in our summers? I mean, we always have had hot spells in our summers. Anyone who remembers 1976 can vouch for that. And 1974 as well, I think, was quite hot. But these, how do we keep our medications cool, essentially? We don't want to put them in the fridge because they want to be kept between 10 and 25 normally, something like that. So what are the suggestions from official sources as to how to look after that medication when it's 30 degrees C outside, or 35 for our poor unfortunate southeast population? Okay, that's what okay. There is on the aspergillosis website, I have written a whole article about this, so you can read that at your leisure. If you go to the website, go on to search and just type in hot weather, you should find this article fairly quickly. It's probably in the first page or two of the news and the latest updates page. Okay, so why does it matter? Because medicines exposed to too much heat can lose their effectiveness, can change in appearance or texture, and therefore become unsafe to use. This is especially true for things like antibiotics, inhalers, believe it or not, liquid medicines in particular, hormone tablets, and biologics, of course. Something like a biologic is essentially a protein suspended in a liquid, and that isn't going to enjoy being at above 25 degrees C, particularly. Store below 25 means this refers to room temperature normally. It's okay if it's only for a brief hour or two above 25, but prolonged heat for, say, 2 or 3 days, then you're really starting to get into trouble above 25 degrees C. If you're talking about 35 degrees C, probably a few hours is too much. They're not to be refrigerated unless it specifically instructs in the medication notes that you can do that, because the cold can also damage some drugs. Best things to think about: store in a cool, dark place. So find the coolest room of your house where the sun doesn't reach, and keep it there, because that will generally, even when it's 35 degrees C outside, that place will probably be much cooler. In the shade. Several times they've mentioned in a wardrobe in the people making suggestions about this, which is interesting, because these are places where temperature will be much more even and much cooler. Consider an insulated box, but don't put ice in there. That would take it too cold. Just in an insulated box with the lid on, just as if you put ice in there, the ice would stay frozen. If you put your medication in the box without ice, it'll stay at a much more even temperature, especially during the day when the temperatures are peaking. And monitor the temperature with a small thermometer, because if it goes above 25 degrees C, wherever you keep it, you want to know that your medications have been exposed to that temperature, so you can take future action if needed. You can buy inexpensive thermometers online. Avoid, it's fairly obvious, windowsills or radiators. Avoid kitchen cupboards near ovens. Avoid bathrooms that can get hot and humid. And obviously do not leave in direct sunlight. If indoor temperatures go up above 25 for more than a few hours, move medicines to the coolest part of your home. Could be the north-facing room. In my case, my living room is north-facing, and it never gets too hot. Even in the hottest of weather, it's quite rare to get hot in that room. Whereas if you put it in the loft, probably at 30 degrees C on a winter's day up there. Close blinds and curtains. It keeps the rooms cooler. Use fans or portable air conditioners if available. And remember that electronics often generate heat. So your TV, your laptop, even your mobile phone generates quite a lot of heat. Keep them away from that. Pets make a lot of heat as well. You've got random pets wandering the house, warming the air up. If you're traveling, obviously, you're traveling to a hot country, never leave your medicine in a hot car. Always use a cool bag, insulated travel pouch, or a medication wallet. They come with a cooling gel, which you keep in your fridge. You don't freeze them, but then that keeps your medication cool. Maybe that's something you could use at home as well. In hotels, you find a shaded cupboard or the fridge if you're allowed to refrigerate their particular medication. Do not store in your luggage if it may be left in the sun or overheated. You can imagine watching your bags being unloaded after the flight has landed and left on a truck in the direct sun for an hour. So it's tricky. Now, if you think your medication might have been exposed to higher temperature, how would you be able to tell? The medication might look or smell differently. The tablets may have melted, kind of an obvious one there. Crumbled or discolored. These are all signs it's been degraded. Liquids may have separated or changed consistency. In all these cases, you should contact your pharmacist to ask for best advice. They may have to provide you with new stocks if any of these things have happened. Even if you're unsure whether your medicine has been exposed to prolonged heat, talk to your pharmacist about what to do about your medication. They will be able to issue fresh medication, because they of course have full-on cooling rooms to keep their medication from being exposed to too much heat. What do the pharmacists say themselves? Short-term exposure to temperature slightly above 25 is usually not harmful. Bit subjective, that, isn't it? What's a short-term exposure? I would say a few hours. Medicine stored above 25 for several days may need to be replaced. So a few hours is fine. Maybe a single day might be fine, depending on how hot it's getting. If it's at 35, I would suggest it's a few hours rather than several days. Blah, blah, blah. You can, if you've particularly got a particular problem, you can purchase temperature control storage, which is made for the job. And this information was found on these authoritarian websites, NHS, Specialist Farm Service, and so on. So, quick tips. Keep medicine in their original packaging. Avoid windowsills, kitchens and bathrooms. Use shaded, cool cupboards or wardrobes. Monitor room temperature during heat waves. Carry medicine in a cool bag when traveling. Check for changes in medicine appearance and consistency if you feel they've been exposed to too much heat. And if you do feel that's the case, ask your pharmacist about what to do about it.